All right, welcome. I'm so excited to introduce back the amazing Jamie. Jamie is from, Mr. Sellar is from RI International. Today, as I said, is the second session of our cohort coaching series, Crisis Now, Mobile Crisis Outreach Teams, Staffing Models in the SAMHSA Guidelines. And if you're new to our 8 series cohort coaching sessions, I just want to give you a heads up. If you missed the first one, you're going to be able to go back and watch a recording of it. We do encourage you to come to each one of these 8 sessions. Each session is going to approach this topic from a slightly different perspective. After a presentation by Mr. Sellar, then we will have an opportunity for you all to ask questions and, importantly, share information with one another across counties. Let's go to the next slide, please. So very briefly, CARE TA Center is funded through the Department of Healthcare Services, Mental Health Services Act, and I work at CARS, the Center for Applied Research Solutions. While we are grateful for that funding and institutional support, what is about to be shared here is not necessarily representative of anyone except for the people who are speaking. What is CARE? If you're new to the Crisis and Recovery Enhancement TA Center, we are funded to provide training and technical assistance regarding crisis continuum of care and justice diversion in the state of California, in particular to the 58 MHSA funded counties across the state and the 2 MHSA funded city jurisdictions. Next slide, please. We work with a collaborative of phenomenal agencies, including RI International. The incredible Mr. Jamie Sellar is presenting to us from RI today. Next slide, please. We provide a variety of training and technical assistance, which you can see on the right-hand side. If you're not familiar with our work, please go to our website where you can access a resource library, an asset map to find out what are the local crisis care services and justice diversion services in your county. Heck, you could look it up, put in your own zip code or click on an image of your county on our map and find out very quickly. Additionally, as I might have mentioned, we have a resource library with hundreds of resources that you can access, no cost. We also have all of our previous webinars available, recorded online, accessible 24/7, and you can find other information about upcoming services. Next slide, please. So our focus really is on evidence-based practice, community-defined practices, and providing reinforcements to the crisis continuum of care and justice diversion from an anti-racism, diversity, equity, inclusion focused perspective. Next slide, please. Now, without further ado, I am so excited to bring to you Mr. Jamie Sellar. If you were here in the last session, you heard me probably gush a little bit about how much I enjoyed learning from Jamie. Every time I am in one of these sessions with him, I find myself taking furious notes. You all, I'm sure, will find him to be really, really knowledgeable on this topic, having worked in Arizona nationally and now internationally with RI International. But I'm going to stop and just invite Mr. Sellar to introduce himself. After he does so, we will bring up a couple of Zoom polling questions so we can hear from you as well. Jamie.
Perfect. I appreciate it. So I'll go ahead and introduce myself. My name is Jamie Sellar. I'm the Chief Strategy Officer at RI International, which is really a lovely and a beautiful title, but really what it represents is that I've been spending the better part of the last 5.5 years doing consulting, doing training, business development, both nationally and internationally, really around crisis system optimization. I was fortunate enough to have done a few things. You know, when you are a clinician and you've been working for 35 years, you get a lot of opportunity to see a lot of different things. And really what I do most of my time now is take that 35-year history and look to translate it into new communities, into new states, new countries. But really at the core, what I love is crisis work. That accumulated for me in being one of the writers for SAMHSA's national guidelines that came out in February of 2020. And actually, I wrote a good portion of what's going on in the mobile crisis outreach portion of the SAMHSA guidelines based on my work at one of the exemplars here in Maricopa County of running 24 mobile teams a day that really had high fidelity to the model. And it had high fidelity to the model because the model was based on the work that we were doing here in Maricopa County. So I get a good opportunity to go ahead and take that knowledge as a clinician, as an administrator, as somebody who's done a lot of direct service, and try to help communities, try to help facilities, agencies, states optimize their systems so they can create low barrier, ease of access that really is diverting away for folks with behavioral health or substance use disorders, away from emergency departments, away from law enforcement, away from jails as caregivers of last resort. So here's the agenda for today. I'm not going to talk a ton of time. I'm hoping to spend about 10 minutes. Very difficult for me to only talk in 10 minutes. Takes a lot of prep for me to only talk for about 10 minutes. But these are the things that I want to focus on. I want to review on the SAMHSA staffing model based on the national guidelines, once again, that came out February of 2020. I want to talk a little about what it is, what it isn't, what it means to have fidelity. And I want to go into a little bit more of a deeper dive about those co-response teams and what they mean within the SAMHSA guidelines. I want to talk a little bit about the reasoning for the model, what's being utilized in other states, why the SAMHSA guidelines kind of went the direction that they went to, kind of what the goal from a national viewpoint is toward working toward mobile teams. I want to talk a little bit about challenges that we see within the model. And then really what we want to do is kind of talk a little bit about tips and trades, tips and tricks. Now, the reality is I've run mobile teams. I've run them in Maricopa County, 4.4 million people. We are the fourth largest county in the country. And my experience with that has been working in heavily urban, as well as some of the rural and frontier areas of our 9,600 square mile county. So I kind of understand staffing challenges. I understand a lot of the issues, and I've either worked to overcome them in the past or have plans on how you could overcome them. Or provide just support and things that you can't change. But really, we're going to go ahead and try to learn a little bit about maybe some ways to improve your current system. And then really, we're going to be able to do is spend a lot of time having a discussion about what challenges you're seeing in relation to this, and maybe come up with a few answers, a few thoughts, or at least a few ideas on how you may be able to go ahead and challenge some of the status quo and start moving toward a little bit more of an optimized system. But really, the focus for today is going to be around staffing model. So we're going to go ahead and move forward. Perfect. Somebody was reading my mind. I want to talk a little bit about what is mobile crisis outreach teams for those who didn't participate last week. Really, when we're talking about a mobile crisis outreach team, it comes in a lot of different names. Crisis response units, mobile teams, crisis PMRT teams out in Los Angeles. And really what we're talking about is we're talking about mobile teams. So this is not facility based. Should not be going to the emergency departments, should be working out there in the field, should be in a van, should be able to go where they need to go. Working in crisis. And for us in the SAMHSA guidelines, crisis is anything unplanned, really, that you need to go out and work with somebody, anybody, anytime, anywhere. So I can't schedule an appointment tomorrow for a mobile crisis outreach team. I can schedule an appointment tomorrow for an outreach team, but not a crisis outreach team, because if they can wait till tomorrow, probably not a crisis. And if they are in crisis, they probably shouldn't wait until tomorrow. Outreach, really focused on doing work in the streets. This is street level work that we're talking about, where people live, work, and play. If my team is going primarily 70% of the time to emergency departments to meet people who are already there and do level of care assessments, I'm not really an outreach team. I might be mobile because it takes me a van to get there. I may be working in crisis, but I'm certainly not meeting fidelity to the model. And I'm certainly not meeting people where they live, work, and play. And when we talk about a team, we're really talking about a unit, not a program. Frequently, we will hear that there are providers that say we have a mobile outreach team. And really what they're talking about is their program. When we talk about team, and I'm going to go into a little bit more of it, we're talking about a two-person team that once again is working in community. So if we can go ahead and move forward. So as we were writing the guidelines, and the guidelines were kind of coming up, there was a lot of thought that kind of went into it. And what we wanted to do was not make it prohibitive. We wanted communities to go ahead and be successful. You could come up with a dozen ways to go ahead and prove fidelity to this particular model. But if we made it too tough and too restrictive, we knew counties or communities would have a hard time matching all of them, all of the fidelity criteria. And when you tend to not match all of the criteria, communities get very discouraged and they start matching none of them. They start to give up. We weren't looking for that learned helplessness. So we really talked about a few minimum expectations to go ahead and operate a mobile crisis outreach team. The first one in regards to staffing model is, at the very least, it needs to be a licensed or credentialed clinician that's able to go out and work in the community. And the reasons for that is, A, you want to be able to bill Medicaid or Medi-Cal. You got to have a clinician that's going to go ahead and do that. You want to have some form of level of education and experience through that licensure to ensure that you're getting consistency, quality, competency, all of those things that you maybe don't see right up front. But the reality is having a one-person team out in community is problematic for a variety of reasons, which I'm going to go into. But we do at the basic core need a clinician to be able to do that work. Otherwise, we're not going to get Medi-Cal to reimburse it. Can't get Medi-Cal to reimburse it. Then we're not getting some matching through the federal government. This becomes very unsustainable from a model. But if we want to go ahead and have full fidelity to the practice guidelines, and once again, I'm going to advocate that all of you look toward full fidelity, we want to incorporate peers within the mobile crisis team. And this is directly out of SAMHSA's national guidelines. You can go back and look at it as chapter and verse. But we really do believe in the benefits of having a two-person team. And we do believe that having somebody with lived experience is going to increase your outcomes or better your outcomes. Certainly going to help you match what your key performance indicators should be. So let's go ahead and move forward one. So I'm going to talk a little bit about why we focus on a two-person team. There were a lot of reasons for that. Once again, we looked across as the Crisis Now model came out in 2016, which really was a basis for SAMHSA's national guideline. We started to look across the country and started to say, everybody's got mobile teams. Which ones are actually working well? Which ones are supporting people to remain in community? Which ones tend to have, good value? Which ones are low barrier, high access, 24/7? Work well with law enforcement out there in the streets. And really what they focused on pretty heavily were going to be two states. One is Arizona, particularly Maricopa County, where I was working at the time when Crisis Now came out, running mobile teams. The other was Georgia, the state of Georgia, which really has been leaning in for the last 15 years around mobile teams. But the reason for a two-person team ultimately is safety. So if we start talking about trying to divert away from law enforcement in mobile team responses, if I am a one-person team, there are places in Phoenix that I'm not going to go by myself, probably wouldn't be safe, but I'd go with a partner. So what we tend to see across the country is when there is a one-person team, there is an over-reliance on law enforcement to come and provide basically safety and security. Not because there's a legal issue, not because there's necessarily a public safety issue, but just to go ahead and ease some of the discomfort that a one-person team goes out. I think that's very important. And what we do tend to see is good evaluations, good assessments, good interventions can take 75 minutes to 90 minutes. And if I am removing a law enforcement officer or sheriff from their primary role of public safety to go ahead and just be that second person on the team, I'm starting to impact other areas of the community. The second thing that a good mobile crisis outreach team should be able to do is transportation for folks that need a higher level of care if they are voluntary for that level of care and it feels clinically appropriate to do so. So once again, I, as a single person, if I was working a team, I wouldn't bring somebody into a van. Not necessarily because I'd be afraid for my safety. I'm a fairly large individual, but I would be concerned about liability. I would be concerned about what if someone said I did something, assaulted them, stole something, touched them inappropriately. Having that second person would allow me to go ahead and do that transportation in a much safer environment than being solo. So what I have seen across the country is when people are running one-person teams, they're never doing transportation, and rightfully so. Two-person teams are going to allow for that, which once again decreases the role of ambulance or decreases the role of law enforcement. The other is responder support. When we talk about responder support, this is a very tough job. Having two people go out there to share some of the pain, to share the burden, to be able to process with each other and support each other definitely is going to be helpful. What we've seen in one-person teams across the country is that burnout rates or turnover rates definitely start to increase when you are out there, sometimes making life and death decisions, working with a lot of vicarious trauma with the folks that you're hearing. If you don't have a partner as you're doing that, your longevity on the field is going to be very, very low. Crisis work takes a special type of person. And I have yet to meet that person who wants to do it long-term by themselves. I also want to talk a little bit about the primary, what is the primary intervention in crisis? When we start talking about behavioral health, there's a lot of discussion about diagnosis, a lot of discussion about medication. Quite frankly, time is a fairly good intervention. But in crisis work, the difference between strong staff and weak staff is their ability to engage, interact, develop therapeutic alliance, develop that therapeutic rapport that's going to help people move to the next level. So if I've got 2 staff, I've got now the ability twice as much to go ahead and develop that therapeutic alliance. So if I've got 2 people in the team with various maybe a little bit disparate, various levels of education, various cultures, male and female. I now double my chances of being able to engage with somebody. And if I can't engage with them, I can have all the best technical skill in the world, but I'm not going to really support them getting where they need to as easily as if I can develop an alliance with them. So we talked about the reason for a 2-person team. We had mentioned a little bit earlier that lived experience is valuable on a team. So the question always comes back to, if I need a 2-person team, why would I need a peer on the team? And there are a lot of models out there, and we purposely, as we were writing them, tried to avoid a few of them. I have seen teams that were 2 clinicians or a clinician and a nurse. Currently in Los Angeles County, they've got the PMRT team, which is 2 clinicians or a clinician and a nurse, not with lived experience. I've seen models across the country. They're going to be EMTs and clinicians. There is co-responder models where I might have an officer, maybe a plainclothes officer, and a clinician going out there. Why do we kind of lean in a little bit on peers? So if we can go ahead and move the slide forward. Well, we talked about, once again, all the benefits for a 2-person team, but I really want to focus on what the primary intervention is in crisis, and it is going to be engagement. So what we've tended to see, Arizona, half the team, 24 teams are probably up and running in this 24-hour period in Maricopa County. Half the staff working that are going to be certified peer support specialists, or if you can't get a certified peer support specialist, is going to be a behavioral health tech or a paraprofessional that's working that. And what we've tended to see is with the right training, right supervision, our peers do tend to be engagement specialists. They specialize, they are very good at developing that therapeutic alliance, utilizing their lived experience and their stories to be able to engage folks in a way that a clinician who's got a lot of education and experience may not be able to get to in developing that therapeutic alliance. There's something that's very strong about saying, when I had a mobile team come out to visit me, when I was navigating the system, when I was at my lowest point, here's what I did. What we have identified is that peers really are the embodiment of hope and the possibility that recovery is possible. So we tend to see from an engagement viewpoint, if that's the primary intervention, the best people to do that often are going to be peers. So if I need 2 staff, I might as well have one that's primary role is engagement, which is the primary intervention in crisis. The second reason that we start taking a look at for peers within the system does tend to roll a little bit about bang for the buck. So I could put a officer and a clinician out there in the field. If I start taking a look at what it costs to have an officer in the field hourly, after the training, after the the retirement, the employee-related expense, the additional training, the unmarked police car, all of the supervision of the sergeants, lieutenants, captains, chiefs that go into that, it becomes incredibly expensive. What we've seen in Maricopa County is you can almost get 2 full teams for the same price as a co-response team. So when you're talking about bang for the buck, I want to go ahead and increase my capacity so I can see more people, as opposed to having police on scene in a situation that they don't necessarily need to be there for public safety, because all of the skill sets they have are not necessarily needed in that particular intervention. And I don't want to really pay for a little bit more. And then secondly, one of the things that we are concerned about, and Dr. Ramirez kind of touched base on it, is I always hate bringing in a gun into a scene or into a situation unless it's been determined that's going to be necessary for public safety. There is a strong component for folks to have distrust of law enforcement. And when I'm bringing them into a situation that is meant to be de-escalating, sometimes that in itself will go ahead and escalate. So there is a role for law enforcement in behavioral health crisis. Generally, when folks cannot see the advantage of being an active participant in their recovery, when they're in active danger to themselves or others, and they need support in getting to a facility that is going to be able to provide them the care that they need in order to keep themselves safe. Other than that, if there's not a situation of public safety, really what we would be looking for is the best case scenario of having a clinician and a peer out there evaluating that situation. And if it does need to escalate, it escalates. Let's Let's go ahead and move on to the next slide. So I'm going to talk a little bit about peers. I make up, due to my work in California, that there are not a lot of peers working mobile teams. So this is a fairly new concept. We could talk about it being innovative. The majority of states across the country don't really quite understand how to utilize peers in crisis. However, what I can tell you is the standard of care at this point is utilization of peer in crisis. So I'm going to talk a little bit more about it than maybe I would 10 years from now. But one of the things that I saw in the initial questions are everybody's looking to hire. I don't have enough staff. And there's challenges around that. One is not everybody's built for crisis work. Me, I actually like working a midnight shift. I like going out. I like that little bit of adrenaline. Not hard for me to go ahead and work a mobile team and work some odd hours. I kind of dig it. But not everybody's like that. Most people are not like that. Maybe 15 to 20% of the professional counselors, clinicians, social workers, MFTs out there like that kind of cadence, or they like that kind of work style. However, what we tend to find is that you can find peers because you're stretching who you can hire. So peers are quick to develop. So once again, they're coming with some natural engagement. After their certification or after their initial training, they know how to utilize their process. And quite frankly, there's a lot of folks out there that I can hire to put on a two-person team. So if we do take a look at Los Angeles County, and they're running with 2 clinicians, it's going to be much easier if they've got 35 teams running to go from 35 to 70 teams by hiring 70 peers than by hiring an additional 70 clinicians. Once again, peers are quick to develop. I don't need a master's degree. I don't need 2 years of a practicum, internship, supervision to go ahead and get my hours. I need to be able to get my certification training. I need to get my on the job training. And then I'm really kind of ready to go and be part of a team that's out there supporting people in the community. So if we're talking about a 10-year plan of increasing the amount of clinicians that are available for teams, certainly happy to have a discussion around that. But you can get peers up and running in 3 to 4 months. You'll never be able to do that for nurses, clinicians, social workers, and MFTs. As Dr. Ramirez did mention, peers do require a different approach to supervision. Really what we start looking for when we utilize peers in crisis work is if I can create a career ladder where peers actually are moving into supervisory roles and able to supervise other peers, I generally tend to keep them in the field longer, and I believe the supervision is stronger. However, often they're going to get supervision from clinicians. And as you're starting to do that, there is a old school mentality around crisis work or around behavioral health from an employment viewpoint that you don't really get too personal with the folks that you're supervising. When you're working with peers, you're going to get a lot more personal. And really what it does require is a lot of direct supervision. One of the reasons that we can utilize peers in crisis work is because they're not working by themselves. They are definitely working with, not for, but with a licensed clinician working as a team, which does cover each other's, strengths and weaknesses. So peers do require a different approach to training. We're going to do an actual one of these presentations on training. Can't quite remember which one it's going to be. It might actually be the next one or the one after that. I do want to kind of talk a little bit about the role with clinicians and peers. Clinicians don't always appreciate the work that peers do, depending on how long you've been in the field. But we were taught, I got my degree in 93, my master's in 93. They said, you never talk about yourself. Your client should never know anything about you. If not, you're creating a dual relationship. There's boundary issues, there's boundary violations. And what are we really asking our peers to do? We're asking them to expose who they are, talk about who they are and their experience in order to develop that therapeutic alliance, that rapport to help move somebody forward. So as you're thinking about incorporating peers onto your teams to go ahead and stretch your workforce, remember that clinicians cannot look at peers in a one-down position. It is a team approach with each person being valuable. And remember, peers are not assistants to clinicians. And I see that time and time again, where clinicians are thinking, I'm going to do all the work and the peer can drive around and just be my security in case something starts to go wrong, or my witness. Those situations never work. It is very important to talk about scope of work as we're walking through all of these things. Like I said, we're not billing independently for peers. Documentation, as far as all the assessments, a lot of those questions can be asked by peers, but the documentation is still going to need to be signed by that licensed person. So it's very important as you start to incorporate peers into your workforce, that part of your training, part of your concepts is really delineating what each person can do based on the scope of their practice. So these are some of the things that I'm going to talk about as you're starting to incorporate, develop your teams, build teams up, things that I've learned over not a lifetime of working crisis, but really a decade or so working mobile crisis. A success for an individual team is going to be based on that team relationship. So if we're talking about what's the most important factor in the counseling relationship, it's going to be the relationship. If you like the clinician that you're working with, if you like your counselor, if you like your psychiatrist, your chances of getting better, getting into recovery go up absolutely dramatically. If you don't like the person sitting across from you, if you don't have a good relationship, they could be Freud, it's not going to go ahead and work for you. What we have seen is that teams have the exact same dynamic. If I've got two team members that can't get along, don't see eye to eye, don't respect each other, don't like each other, that team is going to be unsuccessful out there in the field. So understand that as a supervisor, as a director, as a manager, half the time what you're doing is ensuring that that team is a tight team, that they've got a rapport, that they watch each other's backs, and that they're working together in unison as opposed to sitting in separate seats and looking in different directions in the van. Teams should be consistent. And by that, what I mean is a lot of programs, you come in and they're going to assign who your teammate is on that particular day. Teams should be consistent. I should be working with a partner, and I should be working with that partner for weeks, months, hopefully years. What we have seen is when we're constantly mixing and matching and moving staff around based on shift availability, who called out, those teams never gel quite as right, and it is going to impact your key performance indicators. Teams should be diverse. So if you can have a team that's male and female, two different cultures, some language capabilities, maybe some different socioeconomic backgrounds, you're generally going to have a much easier time finding the ability to go ahead and support somebody and finding which one of your staff is going to be able to develop that therapeutic alliance or therapeutic rapport fairly quickly. I also like the concept of having male and female staff present, because you can't tell what call you're going out. And if you get knee deep into something and find out there's been some sexual abuse and you've got a team with two males, you may not have the opportunity to get as deep or as develop that alliance as you would like to. Team supervision still needs to occur. What a lot of people tend to do, or I've seen across the country, is I'll do my individual supervision. I'll bring in the peer and have an hour, then I'll bring in the clinician and have an hour. And I do that once a week, once a month, twice a month, whatever my policy or my agency specifies. I'm a firm believer that generally I like to do supervision with each staff individually once an hour. And then once a week, I don't do it individually, or once a month, I don't do it individually. I do it as a team, to be able to work out some of these gel issues, to work out some of these challenges. Where did you disagree in the assessment? Where did you disagree in a continuing care plan? What was going on? What was the thought process? What friction is starting to occur? Now, reality is that team friction is going to occur. You think about it, you're going to be spending as much time with your partner as you do with your family often, at least waking hours. What I have seen is that a lot of providers, a lot of agencies know that success is based on that team relationship. And if the team's having some challenges, they just separate the team. What you end up finding then is that you don't have any consistency and teams are constantly being separated, sometimes working through that challenge. Often working through that challenge is a way to actually get a stronger kind of relationship going. But what it also does is it keeps the merry-go-round from going, where anytime I've got any friction at all with my team member, I'm just going to look for someone else to go to. So don't separate teams at the first sign of trouble. Make sure that if you are separating a team, you got a good reason to do it and that you've tried everything to kind of get there. But once again, the opposite of that is if I've got a truly broken team, keeping them together is going to be problematic as well. There's art and science in work we do. Finding out when a team should be separated and when they should stay together is going to be part of that. And once again, and I mentioned a little bit earlier, you're going to have to create a peer career ladder. If you think about most communities, they will hire peers, and that's all that person is going to be, is they're going to be a peer. They're not moving up to new positions. They're not moving up into management because people will think, well, they're a peer. How are they going to manage the clinicians that are also on the teams? You've got to create career peer ladders. Otherwise, your peers are not going to stay in the job. They've got to be able to understand that there's a goal for them to reach, and that if they put in their time, their work, and pay their dues, there's going to be the next step in their professional evolution, and then a step after that, and then a step after that. So what I see too often in behavioral health is your next job is going to be predicated based on your degree and your licensure. Nurses can only move up in nursing. Clinicians can only move up in clinical. Peers don't quite have that same, so they're not moving up. Definitely need to be able to focus on having a career ladder to move folks up into the system. And the best agencies are going to have peers really at every level.
Thank you, Jamie. Excellent presentation. And I could see people were listening intently.
So from a staffing viewpoint, and I'm seeing through the questions about staff who are willing to work overnight. So what I really kind of want to talk about, or what I can kind of mention, is that's going to be universal. When you are working with people in their homes, it is going to be challenging to go out behind a 7-Eleven or a Circle K or a QT at Tuesday at 2 a.m. It's a little bit scary. So what tends to happen in most communities is people get hired to work the night shift, and the second a day shift opens up, they tend to move in. Conversely, what you're going to find is there are a lot of folks that actually, not a lot of folks, I'm going to say 10%, 10, 12, 15% maybe, that actually don't mind working some of those off hours. And the reasons they don't mind working those off hours is because you're not around as an administrator or a director. They don't like brass. They don't like bosses. They kind of like being out there and kind of able to work themselves. They like to be working out of doors. They don't want to be consigned to an office. So you're going to find those folks, and you got to treat them like gold. And when you treat them like gold, you're going to give them the support that they need, because staff will leave if they don't feel that they're supported. And staff that come in at 11 and leave at 7, when you come in at 9 and leave at 5, are going to feel unsupported. So what we tend to focus on, and I've seen some agencies do this, everybody gets hired to the night shift. That's what you're going to go ahead and get hired in, because people are looking for work. They're going to get hired to the night shift to go ahead and do that. But also you've got to start thinking about a shift differentials. And when you're thinking about a shift differential, the only shift differential that's going to work for you is one that makes you uncomfortable and them uncomfortable. The best compensation is when you both feel like you're getting ripped off a little bit. When the staff feels that they should be getting paid a little bit more and you feel like they're getting paid too much. That's the right amount typically that's going to go ahead and do this. So for clinicians, I've seen it $4 to $8 an hour to go ahead and work those overnight shifts. For peers, I've seen it $2 to $4, kind of depending on communities coming through. Once again, then as a supervisor, I need to do a few night shifts a month to go ahead and be available for my teams, do some of those ride-alongs, because the second they feel that they're being asked to do something you won't do, they're going to look for something else. I mean, this is tough, challenging work. One of the things I do like about the utilization of the peers is, once again, there's thousands, tens of thousands of people out there that would qualify to be peers that want to do this type of work. And it's not going to take 6 years to get them up and running like it would running somebody through the university. So you've got to go out and you've got to find those people. You've got to treat them well. You've got to compensate them well. You've got to give them the support that they need. And you've got to make sure that the work is safe. So if you think about people not wanting to work overnights, why is that? Well, number of reasons. One is, if we take a look at research, people who work overnights tend to not have the same life expectancy as people who don't. I've got circadian rhythm disruption. I've got challenges in the rest of my, maybe I don't sleep well during the day, but primarily when it comes back for me is I don't feel secure. I don't feel safe. I might go to the Circle K at 3 in the afternoon, scarier at 3 in the morning. Don't feel like I have the support. Don't feel like I've got the security. So what you've got to do then is you've got to ensure that all of your policies and procedures, protocols, all increase safety in regards to what the dispatch is. Somebody knows where they are. They're able to carry a radio that potentially can get you a law enforcement officer there in 5 minutes if need be. These are all of the things that are going to get people more comfortable with the work that they do. And once they start to realize I get paid more and I don't have to deal with a boss, they're going to be more likely to want to work that shift. If they've got a teammate that they like, they'll work that shift for years. I know several people that will not pull a day shift if I call them, but they'll work every night shift I give them a call for.
Jamie, that is such golden feedback about looking for the right people and even the more specific dynamics about how to incentivize and motivate people to stay on, because it's a lot of resource that you put into staff when you train staff up. And when we have staff who leave, that is a major drain on the system. I wonder if in the last few moments here, if you could also talk a little bit more about the supervision of peers and where you've seen some of that work really, really well. What has really stood out about really successful supervision of peers in mobile crisis teams, please?
So I think there's a couple things. I think it really comes back to the culture. So I'm going to talk about myself for a little bit. Once again, when I came through, I got my master's degree from Northern Arizona University in '93. There was a ton of time that they talked about me never, ever allowing a client to know anything about my personal life. Not where I grew up, not what my fears were, nothing about who I was. And really what the discussion at that point was, it was almost unethical to go ahead and do something that somehow I was going to get my needs met through. Then when I started working in the field and started moving into management, I would get human resource managers and directors telling me, never let your staff know anything about you. Don't ask them personal questions. If you've got a staff that tells you they're depressed, you now have to do something about that. We don't want to know that. So the old management X style was, I'm just going to look at your work performance. I'm not going to make any assumptions about how, when, or why. I'm not going to ask you any personal issues because I don't want to hear about it. But the reality is that when you're working with peers, that tends to go out the window. Once again, what we're doing is we're asking our peers to be able to present themselves in an authentic way and a vulnerable way to folks that they're working out there in the field. So every staff contact that you have, you still have to assess readiness to work. And, if I've got a peer that's having a very, very difficult time, are they going to be able to be present, alert, oriented, together enough to go out there and work? I might have to make a tough decision of telling somebody I'm not putting them on a team today, take the rest of the day off and go. But I have to be more comfortable getting into the nitty gritty. So, for example, what I used to do with clinicians and peers, if I was doing my supervision with the peers or with the clinicians, I would probably spend about 50 minutes of that hour talking technical, talking about diagnosis, talking about billing, talking about discharge planning, talking about challenges they had with specific clients. I probably spent about 30 minutes with my peers asking them how they're doing. How was that for you when you heard these stories? How was that for you when you worked with that 12-year-old that had cuts up and down her arm, didn't want to go to the hospital, but you knew she had to and had to kind of make that happen? And what I can tell you is I just from personal experience, I've never had that come back and backfire on me. You can get a little bit more in depth and probably need to. If not, you're not being true to the model, especially not that lived experience model, not being true to yourself, and your staff are going to go ahead and pick up on it. So really what you're looking at also then with your peers is making sure that they have the skill set to be able to do the work that they do. So what I have found when I'm working with peers is they are sponges and they want to learn more about actual professional work. They want to know a little bit more about discharge planning. They want to know a little bit more even about assessment. They want to know a little bit more about diagnostic, even though that they're not going to be utilizing in that. They want to know a little bit more about motivational interviewing, trauma-informed care, all of these types of things. And what I've found is the more that you can start to give them of that, the more you can give them behavioral health background because they haven't got a bachelor's or a master's in it, the more they're going to feel prepped to do the work, the less fearful they're going to be out there, and the more they're going to start to like their job. So supervision for peers takes some clinical skill. It takes some fearlessness of being willing to get into some things that you normally are told not to go ahead and get into. And it really is about promoting both your team and each individual skill set so they're confident to do the work that they need to do.
Excellent, Jamie. Thank you so much for this. And I do see that we've got another comment. I do want to elevate that Carrie shared. Jamie, you are so inspirational and I enjoy your presentation. I always feel motivated to start this project whenever I hear your wise words. In the interim, I just want to bring us to our attention. Karen Lovato has put in the chat, small rural counties struggle to fill clinical positions and experience rapid turnover when we are able to fill positions, especially in the current workforce shortage. We utilize MHRS positions for crisis predominantly, but do experience sustainability challenges with not being universally reimbursed. In the last couple of moments here, Jamie, is there anything that you would like to comment on with that?
I think it's absolutely important. And what I will say is there's haves and have-nots. You know, when you have a community that's 400,000, people within your community, you're probably going to have enough need for mobile teams to be able to keep everybody busy 24/7. When you've got some of the smaller counties out there, it becomes a little bit more of a challenge from a funding and reimbursement viewpoint because you're trying to make some financial decisions. If you've got the need for 3 mobile team interventions per day, how do you financially sustain that if I want to pay 2 staff 24/7 to go ahead and be available? So as we kind of talk about the staffing model, the hope, the goal, full fidelity, what we really hope to have is that you've got 2 staff that are alert, awake, oriented, and ready to go when you call. But what I do know is that most smaller communities, what they're going to do is they're going to give a pager to a clinician, hopefully a pager to a clinician and a peer, and say, look, we'll call you if there's something that pops, but you can be home, you can be sleeping, you could be watching TV. We're going to pay you a kind of a stipend to go ahead and carry the pager. And then when we call you, we're going to pay you to go ahead and come on board. So you have to start thinking a little bit about, how do I provide a 2-person response? How do I provide a two-person response in community based on some of those types of things? And SAMHSA guidelines will give you the flexibility to go ahead and do that, as long as you're able to go ahead and still provide 24/7 coverage. And if you're in rural and frontier, instead of being someplace within an hour, if you can be someplace within 2 hours and work through that. So really what we've tended to see from a staffing viewpoint is that you might have a fairly new clinician still paying off student loans that's got a full-time job, 8 to 4 in the outpatient clinic. And you basically get them in a Faustian bind where I'm going to pay you to carry the pager. They want that, they need that. But the challenge is, 2 or 3 nights, 1 or 2 nights out of the week, you might get a call at 2 o'clock in the morning, and within 2 hours, you need to be someplace. So it's trying to find those balances that we're going through. Now, what I will say is that reimbursement is coming. The federal FMAP, or the match that the federal government is doing for communities that can go ahead and support Medi-Cal people, that communities that have 24/7 with fidelity to this, the federal government is going to pay 85% of the fee for that particular intervention. And if we start taking a look at some of the other funding sources that are coming through to be able to support this, we're living in a very interesting time where money is actually flowing from the state and from the federal government to get these mobile teams up and running, because it's so much cheaper to run a mobile team, even if you're not as productive as you need to be, because you're not seeing person after person. It's much cheaper than sending cops, much cheaper than sending people to the emergency departments, much cheaper than sending people to inpatient hospitals that really just need a 90-minute intervention. Certainly much cheaper than sending people to jail for 21 days and adding court costs on that. So the reality is that it's not necessarily inexpensive, but it's cheap, much cheaper than the alternatives if done right. And that's part of the discussion you might need to have to ensure you've got appropriate funding to go ahead and be able to reimburse the staff that you've got to do the work that they love to do, but are keeping them able to go ahead and do that.
Jamie, you are phenomenal. Thank you so much for this presentation. Thank you to everyone who has participated in the chat box and in the polling questions. We are right at the top of the hour. We are excited to meet back with you in the 3rd session. So thank you in advance for your feedback in that feedback form. Thank you to Ruth Santos, our tech manager in the back, to Ande Pena, who has also been helping in the chat box. And most especially, thank you to Jamie. Please go to the CARE website, submit a TA request. It takes just a couple of minutes. We can pair you with Jamie or a number of his colleagues also from RI International, should you have questions regarding mobile crisis units. Thank you all so much for being here, and we look forward to seeing you at the next event.